As we develop and learn about forward movement in blood clot removal technology, it can be tough to ration with continuous loss as a result of lack of access or lack of knowledge.
And my husband and dad, they both dropped to their knees. I had one on my right side and one on my left side. My dad was praying, you're not taking my best friend.
In a world waking up to the dangers of blood clots, how do we continue to move the needle forward?
Not only am I able now to tell others about I was healthy, I was young, but I was also dying. It can happen to everyone.
Every 6 minutes, somebody in America dies of a blood clot.
We're here to change that statistic. Welcome to Taking a Breath, a Stop the Clot podcast.
An award-winning podcast dedicated to bringing awareness of the dangers of blood clots from the clotting disorders community to the world.
With the help of many notable blood clot survivors, we are here to give you the knowledge and the skills you need to prevent this silent killer.
My name is Leslie Lake. I am the president of the National Blood Clot Alliance, and I am a blood clot survivor.
And my name is Todd Robertson. I am the patient engagement liaison for the National Blood Clot Alliance, and I am a 7-time blood clot survivor.
And we're here to stop the clot. When recounting these stories of survival and loss, one key factor echoes throughout: the swift and sudden envelopment of debilitating symptoms. In these moments of confusion and disarray, how do we maintain any semblance of composure and navigate to the safety of professional healthcare workers? Our guest today is a survivor. Through life-saving advancements in clot removal technology, our guest was able to breathe and see another day. A mother, a partner, and a survivor, please join me in welcoming the wonderful Elizabeth Sims.
I'm Elizabeth Sims. Everyone knows me by Libby Sims, though. I got 4 kids and married. My husband and I have been together 10 years. I have 3 daughters. My oldest will be 13 the end of this month. When I have an 11 and 4-year-old. And then my only son, the one I was actually pregnant with when all this happened, he's 3, happy and healthy. My son is Lennox. My youngest daughter is Charlie. Middle daughter is Clarity. And my oldest, that'll be 13 this month, is Rayleigh. It has its days. Any parent will tell you that. But I tell everyone it's a race that'll never end, but you're always going to want to be the winner of. I always knew, even when I was a kid, playing mom with my cousin, I always knew I wanted a big family. So I got it. And they're good. They're really good kids. They have their days. Like this morning, they was trying me. That morning I had woke up and got my youngest daughter. She was 1 at the time. Picked her up, and it was like someone bear hugged me all the way around my chest, my back, and my heart was throbbing. And I went ahead and changed her and fixed her snacks and a couple of sippies and set them in the floor because I honestly thought I was dying. And I sat down for a little bit. I watched Terry. Next, my husband asked if he was in town working, and he said yes. Why? And I told him, I was like, something's off. I feel like I'm about to have a heart attack, but I could just be, overthinking it. By the time he made it home, within like 10 minutes, I was on the couch and I knew myself. I felt like I was fighting for my life. And when he walked in and seen me, he told me, "You're going to the emergency room." So we arrived at Greenville, my local hospital, and they done what tests they could. What they needed to do a CAT scan. I'm allergic to the dye, so they needed something opposite. Well, they didn't have that. So I guess they done x-rays, and shortly after they come in, they told us everything was fine. Everything looked good. My blood pressure was fine, but they was wanting to lifelike me to Owensboro. So me and my husband looked at each other confused at that point. We didn't understand if I was okay. Why was they wanting to lifelike me? Then there was a couple of EMTs in the hallway, and they told us that, we can get her there quicker in the truck rather than waiting on the helicopter to get here. So we did that, and of course it took us about an hour to get there. They was great. There was one guy in the back with me, stayed, talked, kept me calm, checked my blood pressure. Then we got to Owensboro, and then it was just chaotic. Like, I ended up in the trauma unit. There was so many nurses and doctors. I felt like I was in and out of it, but I don't remember all of it. I remember there's so many people. And shortly after then, one of the doctors come in and wanted to speak with my dad and husband. They went out and spoke to the doctor and come back in and explained what was happening and that it was serious and that they was going to bring a paper in for emergency C-section if needed. So that kind of hit me different. Like, this is really a problem, whatever's going on. And my husband and dad, they both dropped to their knees. I had one on my right side and one on my left side. My dad was praying, you're not taking my best friend. And my husband, he was just sitting there like, you just took me from him or something. He was pale. I don't know. I kind of was laughing it off and I was shaking his hand and I was like, hey, I'm okay. I'm perfectly fine. And he's like, no, baby, I don't know. We're going to have to see, about getting some type of help and surgery. And I laughed again. I was like, I promise, Jordan, I'm fine. And I was laying there and like everything just kind of stopped. I don't know if I was dying or like it had just finally let up. But I felt at peace and everyone was still going crazy. But the doctors and the nurses, everyone at Owensboro was so good. Like, they were so caring. I mean, on top of everything, I could have not asked for anybody better. I am thankful for them. Then eventually, we had someone come in and pray with me to make sure that I was right with the Lord, in case things went the way that we knew it could have. I agreed to the surgery. I was awake the whole time, and I had a doctor in there. I can't remember her name, but she stayed over me the whole time, just like talking and patting me and was like, you're doing great, And in my head, I wasn't worried about me. Like, I just knew I had my son in me, and I wanted to make it home to my other kids. My older two knew what was going on, but my 1-year-old didn't. And so that was in the back of my head also, like, I need to get home to her. She's missing me. She's confused. And praying that the surgery went well enough that I got to go home with my son too. And it took, I want to say like an hour maybe, but afterwards, like, they come up and the lady, she told me, she said, I don't know who you believe in or who you pray to, but you've got a set of wings on your back, girl. And I was like, I'm done? And she said, absolutely. She said, you're an angel. And she sent me a picture of the blood clots, and I didn't know how serious blood clots was until they started explaining, like, even a microscopic one could kill you. And then here I was, I had a saddle piece and just many of them. Like, I'm super thankful. I've been wanting to go back and see them because some of the nurses and the lady doctor actually asked to be in the delivery room when I had my son. So I felt like that was, I don't know, it was good. They was there, they helped save my life, but then they seen me bring life. And it was nice. I want to see them and thank them again. I want to start by saying forever thankful, honestly. Like I've said, and I'll say it 1,000 times, not only to the doctors, but the technology. Because without the technology, the doctors may have not been able to. Dr. Cirillo was great. Every other nurse and doctor was also, but they had that technology that also kind of pinpointed on saving my life. And so I want to start by saying I'm forever thankful. And it goes back to no matter how young you are or how old you are, how healthy you are, it can happen. And like myself, I knew something was off, different. It wasn't just something normal you'll get from eating too much tacos or, And I would have not gone to the hospital. I wanted to take a nap, but my husband did make me go. And after my surgery, the lady told me, she said, if he hadn't made you go to the ER, you probably would have never woke up. You would have had a stroke or a heart attack. And that there is something to process. Like, if I would have took a nap, I would have never woke up. So for everybody all over the world, like, if they happen to hear this, they need to hear the fact that the age and your health does not matter. I had no idea, absolutely no idea.
Oh my gosh. I mean, sitting here and listening to this is so emotional. We've had several fathers actually on the show since it started who lost their wives and mothers to their children to pulmonary embolism because people didn't know the signs and symptoms. People didn't know that blood clots are a risk with pregnancy. And Elizabeth, I know this is your fourth child. Came in with he was a doozy,
Yeah.
the fourth one. But how was the pregnancy up until this point? Was it normal? Had you had any other issues with any of your other pregnancies?
Everything was good. All the tests was good. I mean, I was healthy. I thought I was healthy. He's healthy. So it didn't make no sense to me. But
Did any of the doctors ever talk about blood clots as a risk of pregnancy or from pregnancy?
no.
Okay. So you've had time to reflect on all of this. What would you like to say to the clinical community that treats women having children, having babies, so that they too can learn about the risks of blood clots?
Pass more awareness is what I'm going to start with, because not everything is just, normal pregnancy problems. Like you said, blood clots can come from a pregnancy or form, within. And that's something that should, at least be spoke over. So you can keep that in the back of your mind if you start having these symptoms. Well, yes, I'm large and pregnant, but I should not be hurting through my chest or, blood pressure just skyrocketing. I think it's something they need to, even flyers whenever you start your pregnancy, just information on them about if you have these signs to come in. So maybe they can figure out if it is just something normal going on with pregnancy or something deeper, like a clot has formed.
Yeah, I think that's really important and great advice. And for people who are listening today who are thinking about getting pregnant or are pregnant, or spouses or partners and the clinicians that listen, we've got to educate people that this is a really important and dangerous thing that can happen, and to be on the lookout for signs and symptoms. And it's one of the reasons why the Get Out the Clot program is so important, so that we can spread that awareness, just make people aware of this. You made a comment that I thought it reminded me of my experience of a pulmonary embolism a little bit, which was I knew it wasn't normal. And you
Yeah.
said, if it doesn't feel normal, go get checked out. And that is such important advice to give people. In my case, like, I was one of those people who would never go to the hospital, but what I felt wasn't normal. And I think that was you too.
Yes, absolutely. I'm the same. Jen can tell you, my husband, if he was here, he'd be griping about, I never go to the doctor. But you and I had, kind of the same experience. You knew it was not normal. Your body, I don't care who you are, if you've never experienced, hopefully you won't ever experience blood clots, and it may not be that, but you know your body. So if something is that extremely off, instead of like I wanted to do and take a nap, just go to the ER like I did, or, wherever you need to go to get checked. If it's so off, you're questioning it yourself, like, what could this be? Then it's kind of necessary just to go on and get checked.
Yeah, absolutely. It can be the difference between life and death. Just making that one decision.
I'm so glad you're still here too, also.
Oh my God, so am I. We're both very, very lucky that we're here. So you ended up having the procedure, which is referred to as mechanical thrombectomy. It's something that most people probably have never heard of. How did the doctors actually explain the procedure to you? Do you remember?
A little bit. They was talking doctors, and I said, you got to kind of talk dumb to me. They said, well, it's kind of like a straw technology that just, kind of sucks them out. And I was like, okay, that makes sense. Now, I'm not your dictionary on the technology they use, but I'm pretty sure that's how it works. It's basically like a little straw that's just sucking what they can of the blood clots out, which it works. It's great.
It's a great way to describe it. And it's kind of a new thing for blood clots that has been introduced. What did it feel like? So you're getting this procedure. You had really been struggling. You referenced the bear hug. You're having a hard time breathing. You have this procedure. How quickly did things get back to normal for you?
literally as soon as it was over. I was laying there and I could just tell, like, the lady who was in there with me, I cannot remember her name, but she told me it was over. And I think just the thought itself that it was over and I made it got a lot of weight off my chest. But once we actually made it to the room and I was laying and breathing, I was like, wait, I can breathe. This whole time I've been thinking I was just fat and pregnant. I couldn't breathe because I was big and pregnant. But it was these clots that was like taking over my lungs. So within minutes, I mean, I felt brand new. Like, I was so happy. I was big breathing too. Y'all, you would have laughed at me if I was like, it felt so nice to breathe. I didn't know I wasn't breathing. I just knew I was hurting.
So this is amazing. This, you referenced it, the technology. The doctors have the technology to do this. And so just like we want people to know about signs and symptoms, we want people to know that this treatment exists because it does suck the clot out. Exactly what you said. It's like a big straw taking the clots out. And then you can breathe again and you start to feel normal again. So how has all of this, this experience, how has it changed your perspective on life and motherhood?
A lot. I'm just going to say a lot. Start with that. It's changed a lot. Motherhood's always been like my number one top tier. Like, I put my all into it. But ever since that happened and knowing that I was laying there on like desk table and I was praying so hard. I joke around all the time and I say that I prayed so much. God was like, Lord, she really is annoying. I'm going to let her stay a little bit longer. But I prayed so much to just be able to go home with my son, watch him grow, watch my daughters grow. And now, especially my oldest, I've said that she'll be 13. If I hit my arm a couple weekends ago and she's like, Mama, you know what that can do? That could set up a clot. And I'm like, it's okay. Like, I'm good. But it's kind of opened like a door. My husband, like, he stays so on top of my health. Like, if my watch goes off, like my blood pressure's up, he says, go get your baby aspirin. I'm like, don't treat me like I'm 80, sir. But I think it's kind of helped us. We was always great. They always cared for me as much as I cared for them. But now, like, you can actually see them wonder and worry. Like I said, if I hit my arm or if I fall, they're like, Mama, you got to watch yourself. But that also lets me know that I've talked to them enough about blood clots that they're kind of aware. It may not be a hard hit that may cause one. It could be something totally, working within. But I have put that little bit of knowledge in their brain. So I think after all this has kind of brought us closer, I think everything that happens for a reason.
Well, we want to thank you for coming on the show today and sharing just an incredible story. We are so thankful that you're okay. We're so thankful that your baby is okay, and for being an ambassador to share information about blood clots, because what you've experienced by sharing it will save lives. And we really appreciate you being an ambassador to help stop the clot and spread the word.
Well, thank you guys. It's been a pleasure. Y'all are all so kind.
Life is all about process. Though we can feel complete in our present moment, we are still able to learn, change, and embrace the reality of a future we've yet to see. Here to discuss computer-assisted vacuum thrombectomy and the future of life-saving treatment in conversation with Leslie Lake, this is Associate CMO for Penumbra, Dr. Venkat Tummala.
Well, thank you for having me on the podcast. Great to be here. Congrats on the work that you and your team has done, Leslie, in bringing awareness around such an important topic, pulmonary embolism. And I am very fortunate and grateful to be part of this conversation today with you. I am Venkat Tummala. For our audience, a little bit of background on my end. I'm an interventional radiologist. I have been in private practice for about 15 years in Central Florida, taking care of patients from various disease states, but also venous thromboembolism as one of the focuses of my practice. I also serve as an Associate Chief Medical Officer at Penumbra. My journey so far has been very rewarding, and I feel it to be a privilege to be able to contribute to this space and bring awareness along with folks like you to this important topic.
Well, thank you for that. And I was thinking about you yesterday and today. Talk to us about the evolution of your career in this space, particularly because I feel like a lot of things have happened or been fast tracked over the last couple of years, and it's really taken longer than that. But you've been on the front lines of VTE for a long time, and what you're seeing now, how the treatment options have changed, hopefully for the better for the patient community, and where you see it going.
Great question, Leslie. In the past 15 years or so, there is more and more attention to the disease state, which is great. We want more awareness around the disease state. To your point, the technology has taken leaps and bounds in the past few years, especially. So, what used to be a disease state, a little bit of fragmentation of care, if you will, inconsistency of referral pathways, and even from a treatment aspect of it, the guidelines are still lagging in the space. But the technology took a huge leap where we are able to now perform these procedures in a single session for the most part, avoiding ICU when we can, even mitigate the risk of bleeding complications. When we used to do these interventions with primarily catheter-based lysis a few years ago, and now more and more mechanical thrombectomy seems to take front and center stage to evolve into a single session thrombectomy. So I feel like we are still in infancy in that regard. There's a lot more work to do, and I'm hoping in the times ahead we'll have more tools at our disposal. We'll, hopefully with more awareness, we'll identify as many patients as possible, risk stratify them, and then give them the appropriate treatment that is needed. Not to mention, even clinical data is being pursued at a pace like never before, and I'm hoping some of that will translate towards much needed change in guidelines when it comes to pulmonary embolism patients.
Yeah, for sure. And perhaps not just pulmonary embolism, but maybe even DVT in the future as well.
Oh, for sure. And I think we should see that as a venous thromboembolism disease, right? So multiple DVT patients, DVT is a risk factor for pulmonary embolism. And so evaluating a patient from that mindset will be a wholesome approach, if you will. And to your point, I do think that would be part of the workup as well. And even the technology and data in that space will also be concurrently adding value when it comes to these patient cohorts.
So talk to us a little bit about what mechanical thrombectomy actually is. I mean, you and I live this every single day, but for the folks that are out in the audience listening to this, explain what this is. And then maybe actually we should take this a little bit higher for those that are in the audience listening, exactly what VTE and venous thromboembolism are or is. I'm not sure if it's plural or singular, but this is something that has a lot of words to describe a very scary thing. And so we'd love to talk to you about what it is, and then the treatment options, and really what mechanical thrombectomy is, and how that has evolved very quickly in the last few years.
Certainly, Leslie. I would go with a singular venous thromboembolism, but it's a loaded question. So let me break it up. Taking a step back about the disease state, venous thromboembolism is essentially blood clots in the venous structures, be it lower extremity or upper extremity, and then that also includes a patient cohort that had this blood clot travel to the lungs and in essence became a pulmonary embolism. So a patient, when they can present with a deep vein thrombus, which is blood clot in the leg or in the upper extremity. Or we can also find patients with a clot in transit, which means a DVT that is in the process of becoming a pulmonary embolism. Or they may present with a pulmonary embolism to begin with. And so there are many risk factors to this. We will dive into that in a little bit. But from a treatment approach, mechanical thrombectomy in the simplest terms is essentially we are vacuum cleaning the lungs or the blood vessel that has blood clots, right? And as time has progressed, we are seeing now technologies allowing us to perform these procedures very effectively, but also without compromising on safety. Right? To me, that is an important aspect of treatment decision making as well. And so at the current time, mechanical thrombectomy will allow me as a physician to be able to try to treat the patient in one session, be able to clear the clot so that we also we mitigate the risk of pulmonary embolism, which we all worry the most about is mortality in the short term. And also pulmonary embolism has long-term consequences as well. Patients have a syndrome that is named as post-PE syndrome. And I know from previous conversations with you, you've been through the process. There is some anxiety around it. There are some long-lasting effects around the disease state itself. And so where we're able to get to these patients, hopefully early on, but we have the technology now to be able to do it in a fast and safe manner so that we can apply this or sort of offer this to the broader audience.
So we know that the estimated data is estimated because we don't have a national surveillance system in place, is about 100,000 people die from VTE every single year, which is the pulmonary embolism. And about 900,000 people overall will get a VTE or blood clot in either their leg or their lungs. There was always a perception up until maybe recently, and I would love to get your viewpoint on this, that mechanical thrombectomy was only used on the riskiest of risky patients. And so is that true? Is that a myth? Is it evolving? Those patients like myself, I didn't have mechanical thrombectomy. I wish I had had that as an option to me, because it sounds like for a lot of patients, their vital stats return, particularly their oxygen level return pretty quickly, and they're able to actually start breathing again. And I know in my case, in so many people, the lack of oxygen and just the clot itself made breathing very, very difficult. It's a terribly scary thing to go through, but kind of walk us through that risk evolution, if you will, of MT.
Absolutely. I mean, not able to take a deep breath and feeling that you're not getting enough oxygen is a real terrible thing. And I know you had to go through it. I know if we can avoid that, right? So from the mechanical thrombectomy aspect of it, one of the things you mentioned is rapid recovery of patients, right? So to me, on-table improvement in hemodynamics, for example, slowing of the heart rate in these patients, which I know then I've done enough job to offload the right heart, which is the reason patients die from pulmonary embolism, is right heart failure. So if I can get in there, rapidly pull that clot out. And to that means, in the last 2 years, Penumbra has added a game-changing technology to the aspirational systems. Adding a computer to the aspirational system, what we call now CAVT, which is computer-assisted vacuum thrombectomy, is enabling us to remove these clots at a pace that we've never seen before, at a much safer profile, and also have patients rapidly improve from, like I mentioned, hemodynamic standpoint. We're also seeing shorter hospital stays, quicker discharges. We're also following these patients in some of the registries, and we are seeing great improvement in quality of life outcomes. Going up to a year is what we're studying, and it's great to be at that place now with CAVT.
I'm really looking forward to seeing the data around the quality of life, because that is a big deal for the patient community, because they do have a poor quality of life typically when they have these very severe pulmonary embolism. Walk us through for the audience how this disease state, I'm going to call it a disease state, how it actually presents itself. What are the signs? What are the symptoms?
An excellent question. So PE or pulmonary embolism is known to be a great masquerader, right? So you combine that with lack of awareness around the disease state from a patient or a physician perspective. There is a study out there that has reported that failure to diagnose is the most important cause of mortality in pulmonary embolism. Misdiagnoses can happen up to 50% of the time. Delay in care, at least a quarter of patients might experience a delay in care as well. So these are all pretty big challenges. And like I mentioned, the fragmentation of care, the inconsistency in care, not having standardized protocols also add complexity to the issue. But from talking about the symptoms and signs of pulmonary embolism, the symptoms can be quite varied from patient to patient, but know this, most often they present with shortness of breath, chest pain or chest discomfort, palpitations, lightheadedness or syncope. They're getting tired easily, and they're just not feeling right. Any of those can be a symptom of pulmonary embolism. Recently, I came across a patient, Elizabeth, who is 27 years old and an expecting mother at 31 weeks postpartum. And she felt short of breath, and she didn't think much of it. She was going to take a nap and hoping that it would get better. However, lucky that her husband insisted that she needs to go to the hospital, and which to me goes to your point. That awareness can help with saving patients' life. The sooner we come into the hospital, the better off it is to be able to be diagnosed. And so fortunately for Elizabeth, she was rapidly diagnosed with pulmonary embolism, and she was lucky at a place where they had CAVT, so they employed CAVT to remove her clots quickly from the lungs, and there was a rapid recovery. She got discharged in a day or two after the procedure, and then she went on to deliver a very healthy baby at term. I mean, that's a huge success story. To me, we should see more of those outcomes as we bring awareness around this topic. And so on the science part of it, if you talk about when they're present from a physician perspective, I find these patients tachycardic, fast heart rate. I find them tachypnic. They're breathing at a faster rate. We find oxygen saturations to be low. However, the gold standard when you suspect a pulmonary embolism, typically we do a CT angiogram to confirm that there is pulmonary embolism, one. Secondly, we want to know the amount of clot burden, location of clot. But more importantly, we want to know if there is right heart strain. And like we talked about previously, knowing that can change the risk stratification of a patient, and we can try to prevent right heart from failing and potentially save life.
So you've mentioned right heart strain a couple of times to us now today. And for the audience, walk us through why that is so very important. And then I want to come back to Elizabeth and talk about her situation.
So people think pulmonary embolism in general, the oxygen level is low. That's probably what causes mortality. But in essence, it's a disease of the heart, right? Although there are blood clots in the lungs, the right heart is trying to put blood into the lungs. And so with the clots sitting past it, it may be strained. And so if the clot burden is severe enough, and if somebody has comorbidities, for example, they may have COPD, they may have cancer, other things that they may be suffering with, those patients are especially vulnerable to have that right heart fail. And when that happens, the right heart then leads to left heart failure, and it's called a spiral of death. In essence, it basically patients, once they get to a critical state of compromised heart function, they deteriorate rapidly, and then we'll have to do a rescue phenomena or rescue therapy to bring them back to life. But one other thing to add here, there is a bucket of patients, what we call by risk stratification, the intermediate risk PE patient. Okay, just to take a step back and say there is this extremely severe patients which are high risk, who are, have low blood pressure. They may be coding in the emergency room or in the ICU. Fortunately, those are 5% of PE patients. There is another bucket, half of PE patients have low risk PE, which for the most part, they need to be diagnosed and they need to be managed medically with blood thinners. But the remainder of 45%, a pretty big bucket if you will, are intermediate risk PE. As of today, the current guidelines in those patient cohorts, they suggest managing them medically unless they are deteriorating clinically or they're worsening or decompensating in the hospital stay, right? So you have to wait until somebody decompensates before you can administer advanced therapy, right? So one thing that Penumbra is invested in now is a randomized control trial to exactly answer that question, which is the standard of care right now is medical management only, with the exceptions I mentioned in intermediate risk PE. Is there benefit from effectiveness and safety using CAVT as frontline therapy along with medical management and see how these patients perform? It's called STORM PE trial. The trial has completed enrollment. We're expecting to present this data and patient outcomes in a few weeks at TCT this year. I'm looking forward to that, and stay tuned, more to hear about that.
It does. I thought of you again last night because I'm on a guideline committee, VTE guideline committee for something completely unrelated. And it's a group of physicians that are in a very specialized space. And mechanical thrombectomy never came up as a treatment option. And this is exactly what you're talking about, that we need to break down these silos. It can't just be, a small group of people in the VTE space. We have to break down these silos. And you're right. What if Elizabeth had gone to a different hospital that didn't have this capability? She probably wouldn't be here with us today. And thank God she is. But we need to do more to break down those silos and get the word out. And that's why something like Get Out the Clot campaign is so very important, because there are ways for us to really move across those different multidisciplinary specialties, including the PCP. because people don't realize what an important role they play with the patients. And so we want to make sure we're reaching all of these disciplines. Anybody who touches the patient needs to know that this exists as a treatment option. So let's get back to Elizabeth, talk about Elizabeth, because that's really one of the reasons why we're here today. She was pregnant. She was at 31 weeks, I believe you said. Why is pregnancy such a risk for VTE? I know the CDC has a lot of data around this that would suggest that it's one of the leading causes of maternal mortality in the United States, which is mind-boggling when you think about it. That should be a reason for all of us to be aware of signs and symptoms and also treatment options. But what is it about pregnancy in particular that lends itself to VTE?
That is a serious risk for a pregnant patient. We're also risking 2 lives, maybe more, depending on if it's a twin gestation or not. But the crux of it is pregnancy by itself is a hypercoagulable condition, which is the blood is more prone to clot than usual. It has to do with hormonal changes that are associated with pregnancy. Additionally, the gravid uterus putting pressure on the venous structures can also have patients prone to develop deep vein thrombosis that can then translate into pulmonary embolism. So to me, that awareness there goes a long way. To your point earlier, anybody who touches these patients, it can be a primary care physician, right? Sometimes a patient with DVT might end up in a primary care physician's office rather than an emergency room. Identifying that patient, 1, suspecting it based on awareness, 2, doing the appropriate testing to confirm or deny the diagnosis, and then if it is a deep vein thrombosis, put them on the appropriate treatment so that we can mitigate or reduce the risk of having a pulmonary embolism. And at the same time, once there is pulmonary embolism, the same thing. It should be of back of your mind in a pregnant patient or even female patients who are on oral contraceptives, right? That's another risk factor that we should be, patients on those medications with the appropriate presentation, we should suspect them. We should do testing to avoid or deny or confirm the pulmonary embolism or DVT diagnosis when appropriate. So pregnancy in general poses that problem and is a major risk of mortality, both for the mother and the expectant mother and the unborn child.
And in her case in particular, talk to us about, my understanding was Elizabeth was in the emergency room or in the operating room, and there was a OBGYN team in place. There was the interventional radiologist in place. Like, what was Elizabeth's team all about? Who was doing what?
So goes to say multidisciplinary approach makes all the difference in patient outcomes, right? No single person knows it all. So to me, from Elizabeth's perspective, you probably have, when she came into the emergency room, the ER doctor did appropriate testing in a timely manner, diagnosed her, put her on a blood thinner, and made the appropriate phone call, which is a risk stratification call, and then which may involve multiple specialists, multiple interventional specialists. We have pulmonary and critical care colleagues that also are in the decision making. Some places have hematology, cardiothoracic surgery in addition as well. But all of us put together, what is the best thing for this patient in the moment? And in Elizabeth's scenario, they decided that she was an intermediate high risk stratification. So they thought she would benefit with advanced therapy, and they employed CAVT here, which they successfully removed the clot in a quick fashion. And then she rapidly recovered and then made on to go home in a couple of days after the intervention. And then the GYN part of it, the OB part of it, is somebody that now was not only part of the decision-making process, but also on further longer-term care during her remainder of the pregnancy and postpartum status. Even postpartum is a risk factor for venous thromboembolism with the shift in hormones and stuff, right? So for her to be part of that is following the patient through their journey. And I'm very thankful Elizabeth came out of this strong, healthy baby at term. And so to me, that conversations and breaking the silos, having that multidisciplinary approach will allow us to identify patients early, risk stratify them early, and treat them appropriately based on current evidence, based on the available resources, as you saw in her scenario.
For people who are listening to our podcast today, I certainly hope if you have interest in learning how you can move this forward in your own state, you contact us at NBCA, because we have the toolkit now to put all of this in place. And I think just this general awareness on the Emily Atkins Family Prevention Act will go a long way to saving lives, not just in Florida, but hopefully across the country now as well. I just want to tell you how very proud we are to work with you and with Penumbra and all of our partners, SIR, PERT. I know I'm probably leaving out a gazillion other organizations, but it does take a village to make this happen. And we have seen such a big move in the last few years. May it continue. May we all continue to be working together for the goal of saving lives, and also call upon all those folks that are, legislators across the country and at the federal level to listen to us and say, hey, this is, to your point, this is a leading cause of mortality in the country that's so preventable. And we have an obligation to save these lives. So calling on all of us to work a little bit harder, reach across multidisciplinary verticals and get everybody involved, because we can get out the clot and we can stop the clot. And it's wonderful to see. So I'm very proud to be working with you folks and have NBCA working with Penumbra as well.
Well, Leslie, the feeling is mutual, and I'm proud and also very excited to partner up, both individually as well as from a company aspect with MBCA here. And the mission is clear, right? Bring awareness around the topic. We have tools as of today to effectively treat these patients. So having those silos broken down, having the conversations among multiple specialties that are involved in patient care, and hopefully that will translate into saving patients' lives and changing their lives for the positive in times ahead. So we made some ground. There's a lot more to go, and I'm very excited and looking forward to collaborating further. Again, I really appreciate the opportunity to have this conversation with you here. Time flew by, and hope to talk to you soon another time.
Well, thank you for joining us here today, and you've already made a huge difference. I mean, Elizabeth is living proof of what this new technology can do. It's so interesting, in NBCA, we have so many patients that come to us, and we're seeing more and more people who have actually had thrombectomies done, and their return to normal life, when they talk about how quickly they normalized, is an amazing thing to see and witness. And I just hope we have more of that. So looking forward to working with you and moving this forward, and hopefully 10 years from now, we'll get you back on the show and we'll be like, wow, remember when we were first starting to introduce standard of care? And it'll be just, hey, it is what it is. Like, everybody will know about it.
There you go. Hopefully that day will become sooner than later.
Yes,
and,
I agree. I agree.
I look forward to the collaboration, and thanks.
Thank you for joining us on another episode of Taking a Breath. We want to thank Elizabeth one more time for joining us today and sharing her incredible story. A special thank you once again to Dr. Venkat Tummala for sharing his expertise and all the outstanding work Penumbra continues to accomplish. For more information on risk prevention and community, please visit stoptheclot.org. And for more information on pregnancy and clotting risk associated with pregnancy, please visit Stop the Clot, Spread the Word /pregnancy.
We know the patient because we are the patient. Together with listeners like you, we can collectively stop the clot.
For more information, visit stoptheclot.org. Another Everything Podcast production. Visit everythingpodcast.com, a division of Pattison Media. Subscribe wherever you get your podcast.